Very kind intro. Thank you, Jim. So I'm going to start today, if I can get my slides to move, just 1 second, by giving you an introduction and overview of remission of type 2 diabetes and kind of give you a history of what happened to me as a dietitian and how I've seen the field change, and it really is an exciting time. So I'm going to start by, like I said, telling you what I used to do as a dietitian in the NHS. I'm then going to move into, as Jim said, my interest, which is the pathophysiology of type 2 diabetes, how that relates to remission and why that's important. I'll then be covering the major dietary approaches that we currently have evidence for, the approaches I think that are hopeful that we can use in the future, and again focusing on how they work in terms of the pathophysiology. And finally, a few notes that I think are important in considering how we interpret data from dietary studies. So what you're looking at the screen here is the traditional dietary approach that I used back in 2008, like most dietitians all over the world, in managing patients with type 2 diabetes. So you would typically aim for a weight loss 5 to 10% body weight, so maybe 5-6 kilograms, slow and steady, nothing dramatic. And the rationale for that, it's achievable. You're going to get reductions of blood glucose, lipids, and blood pressure. And I think the really key word here is management. You're managing the condition and the risk factors. Would you have got remission of your condition though? Would you have been able to come off your medications? We don't have precise data of the prevalence of remission or the likelihood of remission with 5% weight loss, but we can extrapolate from some studies that have been done. So the direct study we'll be talking about today, if you lost 0 to 5 kilograms in that study, your chance of getting remission at 1 year is 7%. The look ahead study was a bit more intensive. They lost 8.6% of body weight, and prevalence of remission at 1 year was close to 12%. Using a Mediterranean diet with 6 kilograms of weight loss gives us 15% likelihood of remission at 1 year. That same study also had a control arm with a low-fat diet, and the weight loss was 4 kilograms, remission was 3.6. Now, this data isn't straightforward to interpret because the populations were quite different. For example, in the Esposito studies in 2014, the participants were newly diagnosed with type 2 and they weren't on any medications to begin with. But it gives you an indication of how likely it was with that approach we were using that we would really help our patients get off their medications. The other thing I should just add that makes it challenging to interpret the data, and this is still true today, is the different definitions that we use for remission. So in direct, this is used commonly in the UK, an A1C which is less than the diabetes threshold for 2 months and no medication counts as remission. So if you are pre-diabetic or in the pre-diabetic range, that still counts as remission under that definition. That difference is acknowledged by the look ahead definition, where partial remission was if you got from diabetic range to pre-diabetic, and complete remission is if you achieved normal blood glucose concentrations on no diabetes medications. And the Esposito study, similar to look ahead, but as I mentioned, these were newly diagnosed patients and none of them were on medications anyway. So that's a brief intro into the story of remission and how exciting it's been to see that change. I'm now going to move on to some very basic pathophysiology. So effectively, there are 2 primary things that go wrong as a person develops type 2 diabetes and that causes hyperglycemia. And that is, the first thing is defective insulin secretion. So the pancreas is not producing enough insulin. And I should emphasize type 2 diabetes does not and cannot occur without, I've called it beta cell failure here. Better put is the beta cell functions or dysfunctions to such an extent that it's not producing enough insulin. And this is important because very often you hear type 2 diabetes defined as insulin resistance. And insulin resistance plays a role, but it's not the only thing that causes hyperglycemia. You would not get hyperglycemic concentrations in the diabetic range with normal beta cell function. And you can see in this figure the decline in beta cell function that occurs as a person develops type 2 diabetes. And one of the key characteristics of a healthy insulin response is the first phase insulin release. It's this dark line, this sharp peak that comes up and then comes down again. And that is a normal response to a rapid rise of the concentration of blood glucose. So if you're having a drink or a meal containing particularly carbohydrate, your body will recognize that rise in blood glucose and release a pulse of insulin that's role is to get the glucose into the tissues, but also stop glucose from being released primarily from the liver. And that intact first phase response is so important for controlling particularly after meal glucose concentrations. Now you can see what happens as a person develops type 2 diabetes. That peak becomes a small pulse, and later on in type 2 diabetes it's absent, and this is typically when people need to go on insulin to replace the first phase response. Now, if you don't have sufficient insulin, the glucose doesn't get taken up into the tissues, for example, the muscle. It still gets released from the tissues, so the liver. In addition, fatty acids and glycerol from the meal don't get taken up into the tissues, and triglycerides still get broken down from the adipose tissue and released into the bloodstream. And all of this causes elevated glucose and lipids circulating in the blood. And that's characteristic of metabolic syndrome and type 2 diabetes. In addition to the first phase, or the insulin, defective insulin secretion is the other primary thing that goes wrong, and that's insulin resistance. Effectively, the tissues, primarily the muscle and the liver, are probably the most important here, don't respond to insulin as well as they should. So the liver keeps releasing glucose, even though the insulin concentration might be high. Glucose doesn't get taken up into the periphery, primarily the muscle. Again, even though insulin is high, you still get the fatty acids and the lipids getting released from the adipose tissue. And again, that exacerbates the hyperglycemia and the dysfunctional lipid profile we see. Now, why is it important to know this, that there are two primary pathophysiological defects? Well, it's important to know this because this explains, based on the information we have now, how to get remission of type 2 diabetes. So the traditional approach that I talked about, the slow and steady 5 kilograms weight loss, it improves insulin resistance, but it doesn't fix the beta cells. You do not get that first phase insulin response back. What does? Losing a lot of weight and or losing that weight quite quickly. So we think you have to have a marked energy deficit to get your beta cells rebooted and restored again. And our other speakers today will be going into this in a bit more depth. Now let's just step back and look at some history that's led to some of the dietary studies that I'm going to be talking about. So for a long time, decades, type 2 diabetes was considered a progressive disease. And the basis for this is that if you measured, for example, insulin secretion from pre-diabetes all the way to late stage type 2, you would predictably see a decline in beta cell function. So the amount of insulin that the pancreas is able to produce declines over time. We also know that people, regardless of the lifestyle or the medication that people we used to prescribe to people, they would still require insulin at some point, and 50% of people require insulin within 10 years of diagnosis. And so it tells you this was a progressive disease, and that's how we always thought about it. When bariatric surgery was introduced for the management of obesity, when that surgery was done in patients with type 2 diabetes, what was observed was normalization of blood glucose and the ability to remove medications after those patients had surgery. Now, this wouldn't be a surprise if they'd lost 50 kilograms, for example, as can happen. But people were able to come off their medications within 24 or 48 hours of the surgery. So we got investigators around the world thinking, well, what's the mechanism for that? What caused it? And obviously a really obvious thing was an energy deficit, because you need to fast prior to the surgery. There's often a low calorie or a low carbohydrate done to shrink the liver to prepare for surgery. And after the surgery, you're not able to eat as much as you did for quite some time. And so that hypothesis was tested over and over again. There's decades of very, very good mechanistic research now, which quite clearly shows a marked energy deficit helps restore some of this underlying pathophysiology. And a lot of the focus, quite rightly, has been on getting the beta cells to work properly again. Now, most of these were quite acute studies, so you're talking a week or maybe 28 days, something like that. But it very clearly showed why understanding physiology is so important. And this has been a key thing for me in my academic career, and translating that to being a practicing dietitian is that it really emphasizes that what we used to do out of tradition really, and not based on data, was slow and steady weight loss. Now that is not going to get remission of type 2 diabetes, and that advice, it might work for some patients based on their requirement, but it's not based on physiology. Now, so like I said, those studies were all acute. There have been a couple of studies looking at 6 months. The direct study, which I'm sure Adrian is going to go into depth, really tested this in an applied fashion. And it asked the question, if we can get patients to lose a lot of weight, keep that weight off, can we get remission? And does that remission occur because we're restoring the underlying pathophysiology? So this graph shows they were able to get people to lose close to 15 kilograms. This was done in primary care, and this is pretty extraordinary. And they were able to maintain that weight loss for about 12 months. And what you can see, well, what was the likelihood of gaining a remission? Well, let me remind you from the second slide I had that we were talking about a 7% chance of remission if people were losing 0 to 5 kilograms, as you see here. But look at what happens when people lose 15 kilograms or more. 86% of them can get remission of type 2 diabetes at 1 year. If they lose 10 to 15 kilograms, the prevalence of remission is 57%. So the one story here is the amount of weight loss is key. And again, this overhauls everything that I was doing as a dietitian in terms of how I approach practice. But weight loss isn't the only story. This is why the physiology is really important, because you need to have a first phase insulin response, some first phase insulin response, before you start this kind of dietary approach to get remission. Now, what you're looking at here is a graph showing the responders and the non-responders to the same intervention. So the responders are the people that got remission of their type 2 diabetes, and the non-responders didn't. And you can see on the left-hand side of this graph, the very left-hand bar, that is the first phase insulin response in responders before they started the diet. So you can see they have some insulin secretion. After the diet, that's the middle bar on the left-hand side, they get a doubling of the first phase insulin response. And the right-hand bar on the left-hand side of the graph in responders is after they were on weight maintenance. So what you're seeing here in the responders is you have some first phase insulin response before the diet, you can double it after you lose all this weight, and as long as you maintain the weight loss, so far as we know, you maintain this rebooted beta cell function. But if you look on the right hand side, if you don't have any insulin response prior to the intervention, you're not going to get it back. And this is so important in how we translate our understanding of physiology to giving the right care for our patients. So that's one of the evidence-based ways we can get remission. The other is a low carbohydrate ketogenic diet. I'm not going to speak too much about this because happily we have a speaker from Virta today. But this was basically a low carb ketogenic diet. They aimed to get carbohydrate intake low enough that blood ketones were elevated. That was the aim. And it's quite a nice comparison to direct because they lost about the same amount of weight, 15 kilograms at 1 year. Now, I should emphasize Virta was quite different from direct in that they accepted anyone with type 2 diabetes, however long they'd had type 2 diabetes. And naturally, this included patients who were on insulin. Direct excluded anyone who had type 2 for more than 6 years, based on the knowledge at the time of what was likely to get remission. And they didn't include patients with insulin. So Virta's results are exciting for me because 44% of people were able to stop their insulin altogether, and the other half were able to reduce their dose by half. And all of us who care for patients with type 2 diabetes know no one likes taking insulin. So this is fantastic. And this also makes me excited because maybe this is an option for people who don't want to do a meal replacement type approach, but also maybe in people who've had type 2 diabetes for longer and are on insulin. Now, there's a caveat here. Virta, for good reason, kept patients on metformin. That makes sense clinically because metformin helps prevent type 2, so it prevents the development or the likelihood of relapse into type 2, but it does hinder our ability to directly compare Virta to direct, and I'm sure our other speakers will speak more about this. There's another thing that really excites me about Virta, though, the data they've produced. In any weight loss study, what you always see is maintenance of weight loss at about 1 year, and gradual regain, whether it's 2 or 4 kilograms. People typically regain some weight. Now, what we're seeing in direct, and I'm sure Adrian will talk about this, is there's relapse into type 2 diabetes as people start gaining weight. And probably some of that reason is the beta cell function starts to decline again. Now, what's so exciting about Virta is this slide suggests maybe that's not happening. So at 1 year and 2 years in Virta, they also plateaued and they did regain a small amount of weight. But if you look at the blue line, that is the insulin dose over the 2 years. And not only do you not see patients not needing to go back on insulin, you see the usage of insulin declining as the study goes on. And it raises the questions, for me, could a low carbohydrate ketogenic approach be better at restoring beta cells in long-standing type 2 diabetes? And that's something I'm definitely interested in pursuing in terms of research. Now, both of those studies, they lost 15 kilograms of weight loss. That's a lot of weight. It's very difficult to achieve, and many patients won't want to lose that amount of weight. So a huge interest for me in my research is looking at methods to get remission without needing to achieve marked weight loss or an energy deficit. And I think a low carbohydrate, high protein, and I'll come to why approach could be really helpful here. So what evidence do we have that low carb without weight loss can improve blood glucose in type 2 diabetes? Here's some data published in Japan in 2019. And you can see on the left-hand side, the body mass index didn't change over this study. Now, let me emphasize, this wasn't a randomized control trial. There's no control group. It was a prospective study of patients in clinical practice. But the good thing about recording weight is it's kind of a test of compliance. But effectively, these people were not on a marked energy deficit diet because their BMI didn't change that much. And you can see the A1C reduction is not proportionate to the weight loss. In other words, the reduction in blood sugar is greater than you would expect from the weight change alone. Now, this isn't super controlled. They asked patients what they were eating, and they suggested it was about 30% calories from carbs, and protein was pegged at 20%. But this gets more exciting. I've never done a talk in the last 5 years without presenting data from this group. This is a low carbohydrate, high protein diet. Protein, for all of the studies this group have done, have been at 30% of calories. So it's a high protein diet in patients with type 2 diabetes. And if you look at this data, let me emphasize, they did not lose weight in this study because it was so well controlled. They weighed patients frequently. They provided all food for this diet. So this is a weight independent effect. And the top line shows you the blood glucose concentration in people on their normal diet. That was 50% carbohydrate, 15% protein, and the rest was fat. And you can see how high the blood glucose concentrations were. So that in millimoles per litre, we're talking a fasting blood glucose of maybe 11. Postprandially, it's reaching close to 20 millimoles per litre. This is high. And if you look at what happens, and again, I have to emphasize, without an energy intake reduction, without weight loss, if you look at the black line on the bottom, you see effectively almost a normalization of blood glucose. Fasting goes down close to 7, but the postprandial is going down to 10 or 11. So this is into the pre-diabetic range. And so this data got me really excited. And I wanted to know, is it the protein or is it the low carb? And so this is a study, please don't share this because we're about to submit this to a journal. This is a study we did to test the weight independent effects of reducing carbohydrate without increasing protein. And you can see that this plot shows different doses of carbohydrate. We tested 10% to 30%. They were only for 7 days, and we recorded blood glucose using continuous glucose monitoring. And you can see quite unequivocally, there's marked variation in blood glucose, but there's no difference between doses. We also didn't see a difference when compared to the normal diet or when we just looked at the postprandial period. So this kind of suggests to me, if we're using low carb in type 2 diabetes, maybe some increase in protein is pretty important. And so this is a study we'd begun before the pandemic. Unfortunately, we've had to stop or pause. And this is where I tested the effect of adding or taking out protein against a background of a low-carb diet. So patients with type 2 diabetes were provided with a low-carb diet of 20% of calories. And in randomized order, we added in and or then took out protein from the diet, switching from 15% to 30% protein. So it was the fat content that changed because we kept the calories constant. And we measured again blood glucose using CGM. And you can see this is the 24-hour glucose, marked reductions in blood glucose concentration. So for me, protein is the undiscovered and really exciting story about type 2 diabetes management, and I think the future of type 2 diabetes management. And Jim and I are really interested in this area and trying to do some more mechanistic studies to find out why protein could really help. But basically, we think it's because some amino acids are very insulinogenic. So they can push the beta cells to produce a lot of insulin postprandially. And this is important. You don't want to increase insulin 24/7. You just want this pulse of insulin when a person's consuming a meal. And so we want to look at the effect of different amino acids and protein intake in patients with pre-diabetes and type 2. And this figure just illustrates how we think it works. You get that first phase insulin response back with protein without relying on that massive energy deficit. And this could work better for patients. So I'm just going to finish the last 5-6 minutes or so talking about interpreting dietary studies and why I think this is important. Let me emphasize there's no perfect study. Very often you'll hear rejection of certain bits of data because it's not randomized controlled study, it's not long-term, or even if it's cross-sectional. And you can see today I've presented data from studies that are 5 weeks long. I've presented open label studies with no control group. I've presented randomized control trials. All of them can be interpreted to help us understand type 2 diabetes management. And it all depends on what your question is. So something like VERTA, which is an open label, non-randomized study, it's not necessarily bad or not the gold standard because it's not an RCT. It depends on what you want to know. And for me, studies like that, or even uncontrolled studies that are being done in GP practices that show really exciting results for type 2 diabetes are important because it tells us as clinicians and it tells patients what's possible. It doesn't say it's going to happen for every patient. It can't tell us much, if anything, about mechanism. It isn't necessarily applicable, like I said, to the whole population, but it can tell us what could be achieved. And I think that's really valuable for clinical care. Other things that come up, and I see this with all of the so-called dietary tribes, whether it's low carb, whether it's vegan diets, they'll often present a bit of data and it will say, oh, look at this plant-based diet, look at this keto diet, you get a massive reduction in liver fat, or it's great for type 2 diabetes, and they lost 15 kilograms. And weight for most of the pathophysiology for type 2, as far as we know now, is the dominant factor, and that's also true of liver fat. So if a patient's lost 10 kilograms, it probably doesn't matter what diet they were going on or what they were choosing to follow. The important thing is the weight loss. And this is important in how we interpret the data and apply it to our patients. We shouldn't be saying a low carbohydrate diet or a plant-based diet is superior to other diets unless we've controlled for these factors and controlled for weight loss. And a huge issue that's come up this week is, were there differences in weight loss, and were those differences potentially due to losses in adipose tissue or muscle? If any of you saw the study this week on time-restricted feeding, you might look at the data that showed some weight loss and be encouraged by that, but actually the data suggests that most of that loss is coming from muscle tissue. And this isn't desirable at all for general health, and certainly not for type 2 diabetes management. The other thing I think when I listen to people interpreting data is the role of an energy deficit. And often you might hear patients say, well, we saw a reduction in glucose before any participants or patients lost weight. But the energy deficit will do that even before a participant loses weight. And so this is the rationale for that dose finding study that I presented, because we fed patients so many calories to keep their weight constant. We had patients who had a weight of 110 kilograms. Now they needed about 3,500 calories to maintain their weight loss. So we fed those patients that many calories so they didn't lose weight. And we didn't see a independent effect of carbohydrate restriction on glycemia. So adjusting for weight loss is kind of obvious. You need to adjust for that. Again, if you're looking for superiority of a dietary approach, you also have to consider the energy deficit too. And my final point, and this is so crucial when you hear people say the gold standard randomized control trial is internal validity. This is tremendously hard to achieve in any dietary study. Imagine if I randomized any of you watching to a year-long vegan diet or a year-long meat-only diet. You might have all the best intentions in the world to follow that when you started the study, but maybe you have a bad day. Maybe you lose your job, you go on holiday and you want to eat some steak because you happen to be in Argentina, or you want a cake. Sticking to a diet in real life is insanely hard, and this is why long-term compliance is so challenging in dietary studies. And so what we very often lack is internal validity in studies. And so this is why I speak to people in high leadership positions in dietary guidelines committees who say, oh, well, those Gannon and Nuttall studies, they were 5 weeks long, who cares? But the strength of having a 5-week-long intervention is you increase your internal validity. It is much more likely that people are following the diet that you've prescribed to them. So you are testing the physiological efficacy. And that gives you knowledge you can then translate to patients and say, well, look, if you can increase your protein to 30%, if you can reduce your carbohydrate to 20 or 30%, these are the results that you could get. And that's a kind of intellectual honesty I think we're lacking, and I think is really important. So let me emphasize this internal validity group in my final couple of minutes here. This is as a meta-analysis. Again, we call this the gold standard between a very low carbohydrate ketogenic diet compared to low fat and weight loss. The intervention group was supposed to be less than 50 grams of carb a day, super low carbohydrate. But if you look in some of the studies that they included, 4 of them didn't even check what people were consuming. These were year-long studies. They didn't go back and say, actually, how much carb are you having? But if you look at those of the studies that did, none of them are sticking to what they said they would do. And a couple of them are having a carbohydrate intake that's so high, it's definitely comparable to the low-fat diet. So you are not comparing a low carb to a high carb. You're comparing advice to reduce carbohydrate to advice to eat a low fat diet. That distinction is really important. So with that, that's the end of my presentation, and I've included all the references there, categorized by the subjects that I've talked through. So happy to take questions.
Thanks, Nicola. You can hear me okay?
I can hear you.
Absolutely wonderful talk, and thanks for the dealing with the time zones and everything like that. So we have a lot of questions, and I'll work from the most upvoted ones. The first question is actually similar to the tone you left off on. It says, sure, we can advise quick weight loss, but what about the sustainability of the programs? It is unknown if they may or may not cause long-term harm. And just the general experience of practitioners on sustainability. So can you speak a little bit overall in the sustainability of the various programs?
Yeah, I mean, so in terms of sustainability, as much as anyone would like there to be one particular dietary pattern that can maintain weight loss, the fact is we don't have that evidence. If you look at 1 year, most dietary interventions, low carb, low fat, plant-based, all get quite a lot of weight loss. Admittedly, it's numerically greater with low carb, but it's not clinically significant in my view. But if you follow people up 2-3 years, on average, people will regain weight. In every study ever done, on average, people regain weight. But within those averages, there are people that can do it. And this is why I say randomized control trials aren't necessarily ideal to translate to the patient, because you don't want to crush a patient and say, listen, you're never going to achieve it, because it can be done. The key things for weight loss maintenance is essentially, it's so boring and it's unhelpful to say, it's a diet someone likes and can follow long term. My personal view, and this is just based on patients that I work with, is high protein, low carb is an easy diet to follow in the sense it tends to be quite filling. So eating protein foods tend to be quite filling, and having a nice amount of healthy fat generally is more filling than a lot of rice and low protein. But it's about what the person can follow.
Perfect. That's a great answer. Another question, which is near and dear to my heart and both of ours, I think. You've talked about the impact of protein on insulin and blood sugar levels, but what do you think about the impact of fat intake on insulin?
Oh, great question. So Jim and I are pretty smiling inside because we're writing grants about this at the moment. The general accepted view is that the pancreas does not respond to mealtime fat. So in other words, if you have a meal that's low in carbohydrate, 15-20% protein, maybe really high in fat, you're going to hopefully get a reduction in your insulin. I would caution that we don't have great data on this, and we don't have it in type 2, is that it's important to follow up that postprandial period for a long time. Because although you might not see that pulse of insulin with a high fat diet, possibly you might get a rise later in the postprandial period, and that's what you'd want to avoid. But in general, in my view, this is why a high protein, low carb, healthy fat diet is great for type 2 diabetes, because you get the pulse from the protein, but hopefully with the fat you keep a low insulin curve postprandially.
Yeah, and as you know, we've seen in some human islet studies that a minority of donors do have a response to fats that the majority don't have. So that I think there's room to try to understand the individuality here as well.
Sure.
Another question, I guess more of a dietitian question. Are there certain types of proteins that you consider better? Meat, fish, beans, nuts?
Oh, that's a great question. I really like that as an applied question. So far as we know, it's the amino acids that do it. And all foods contain a mixture of amino acids. And even more relevant, the body can switch some amino acids to others. So for most people, even vegetarians, you'll be getting a good enough mix of amino acids to get this postprandial insulin response. Some people think that it's more insulinogenic from meat. I don't think there's data out there to support that. But nevertheless, so it's the amount of protein that's key. You've got to have a lot of it. And it's interesting to me that many studies with 15% of protein, even 20%, don't get the improvements in glucose that you see with 30%. How do I translate that, though, as a dietitian? Well, it doesn't matter where the amino acids come from to get that insulinogenic effect, but I consider the whole diet. So typically in England, we have quite a high meat diet. So for health reasons, the microbiome, insulin sensitivity, I advise half animal protein, half plant protein. So in practice, that might be some chicken breast or some fish, quarter of a plate of lentils or chickpeas, for example, non-starch veggies and healthy fat, and a tiny bit of carb.
That's awesome. And it also takes care of the next question, which was, what would such a diet look like? So I'll go on to another one, again, a bit on the applied side. What are your concerns for those who have chronic kidney disease, stage 3-5, and diabetes? Could a lower carb, high healthy fat diet, moderate protein be doable? Any experience from your research or clinical practice?
So I have never done research in kidney disease. And in fact, all of the studies that I do increasing protein, we exclude existing renal disease, those people from taking part. As far as the studies that have been done, we now have 2-year-long studies where people are advised to have a high protein diet. That in type 2 diabetes with no existing renal disease has any effect at all. There is no concern whatsoever increasing protein in an otherwise healthy type 2 diabetes individual. Once you get to the later stages, the current advice is to limit protein intake when you get, like you said, to stage 3, 4, and 5 particularly. Now, I'm not an expert at all in this area, so I'm just going to translate what I've been told, is that even that data maybe is not as good as we would like it to be. And there are investigators looking at, in fact, whether insulin resistance might be playing a bigger role in the pathogenesis of renal disease, more so than protein. But out of an abundance of caution, I don't use high protein diets in renal disease.
Yeah, I think some of that work comes from a long time ago, and I think a lot of a lot of work should be done to try to maybe have another look at some of those questions. On the same vein, but now into cardiovascular health, what are your thoughts? Have any of these studies looked at endpoints like CVD and death? What are your thoughts? Obviously, this is a major open question, but where do you think the field should go in terms of cardiovascular outcomes?
I mean, this is really, really hard. I mean, we could spend a week-long conference arguing about this. Cardiovascular disease develops over such a long time. It is so, so hard to get good quality data on what a diet does to endpoints like cardiovascular incidence or mortality. And we have to do that based on a lot of currently surrogate markers. And my view, like I kind of indicated in the talk, weight itself, I mean, adiposity has such a pronounced impact on cardiovascular disease. You have to take that into account when you consider the diet. Let me give you an example. If you had a potentially really atherogenic low carb diet, so super high in saturated fat, low in vegetables, now that's not ideal in my view, but if that person was able to lose 25 kilograms and keep that weight off and be happy and energetic, and because they're happy and energetic, they can do more exercise, that's going to have a far greater impact on their CVD risk than worrying about the saturated fat. And if their atherogenic profile indicated that it might be a concern, well, a statin could be applied by a doctor. So those are the things I take into account. I always use an abundance of caution when I use a low carb diet. The data indicates that saturated fat is far more likely to cause cardiovascular disease than it is to prevent it. The opposite is true of the monounsaturated fat and the polyunsaturated fat. There's large interpersonal variation. So what do? Again, a cautionary approach. If I'm recommending a high fat diet, I promote the monos and the polys, so vegetable oil, olive oil, etc. But I don't stigmatize saturated fat. If people like cheese, if they like a bit of butter with their eggs, great, go for it. And let me just finish by saying, until we have £500 million to have a randomized control trial where we provide all of the food, we have accurate, precise biomarkers for intake, we are never going to get definitive answers on this. Yeah,
I agree. I'm going to tie two questions that are both highly ranked together because they're kind of similar. Is it true that years before there's significant beta cell function loss and insulin resistance, there is a hyperinsulinemic state with the first phase response depleting eventually and leading to insulin resistance? And then that is tied a bit to another question. Dr. Bickman has just written a book, and the opinion there is that hyperinsulinemia could be considered a root cause of multiple aspects of metabolic syndrome. What are your thoughts on hyperinsulinemia, and is blood glucose the wrong marker to follow long term?
Ooh, there's about 5 things to talk about there. So let me start with hyperinsulinemia. The problem with that term is it has no definition. Effectively, you're saying high insulin in the blood. And like we showed, getting high insulin in the acutely postprandially is key to glucose homeostasis, controlling lipids and all of that. What you want to avoid is prolonged exposure to the tissues of excessive insulin. So I don't think he's wrong there. And I think we have enough supporting data from patients with type 2 diabetes on insulin and data from bariatric surgery on the effect of hyperinsulinemia on cardiovascular disease. I don't think anyone has a concern about that. In terms of its role in the development of type 2, I'm really conservative here, and I think we don't know enough. I think it's certainly very possible that's one way many people will develop type 2. So they get hyperinsulin or excessive insulin secretion in the postprandial state. Maybe that's also happening in the fasting state too, from environmental causes or other things. That primary hyperinsulinemia could then lead to insulin resistance and a whole bunch of stuff going wrong down the line. On the other hand, we do have data, and maybe this is in a minority of patients, that actually the first thing that goes wrong is defective insulin secretion. And you could see this in 5-year-old kids And if we measure their insulin sensitivity using clamps and IVGTs and things like that, we don't see insulin resistance yet, but we do see defective beta cell function. And what we know from genetic studies on type 2 and work that's been done, type 2 diabetes is a heterogeneous condition. In my view, if anyone is simplifying this, saying this is what causes type 2, they're oversimplifying things. But I think hyperinsulinemia in 70–80% of people is an enormous problem we need to address dietetically.
Yeah, the geneticists tell us that depending on which one you ask, there's either 5 or 6 pretty distinct types of type 2 diabetes. So I think we need to acknowledge this complexity. So a question from John Little of UBCO and the IPTN. Dr. Guess, do you have any concerns about branched chain amino acids and insulin resistance in your high protein diets?
No, I don't right now. And my view is, so there's observational data showing that branched chain amino acids precedes type 2 diabetes development and predicts type 2 diabetes development. And so the concern is that a high meat diet, which is likely to increase branched chain amino acids, could be causing type 2 diabetes. I think we've got it, it's likely we've got it the wrong way around. What I think is happening is that dietary approach, high meat, person gaining weight, low exercise, causes muscle insulin resistance, defective insulin signaling in the muscle. That causes a greater release of branched chain amino acids from the muscle. And that's an indicator that something's going wrong, not a cause. No one's tested this in a temporal fashion yet. And I know, John, I'm glad you asked me this because we talked about a grant on this. This is work we should do because people are going to be concerned about recommending high protein diets precisely because of this. So we do need to clarify it.
Yeah, I don't have it off the top of my head, but perhaps that's an area where Mendelian randomization can get at cause and effect.
Absolutely, yeah.
Time for one last question, and then we'll finish exactly on time. Can you comment on the effect of low-carb, high-protein diets on non-alcoholic fatty liver disease?
Oh, to me, it's the evidence suggests that's a great diet for fatty liver. In fact, amino acids, there's a lot of work been done. I'll summarize it. If you overfeed fat or you overfeed fructose, you reliably get deposition of fat in the liver. If you co-infuse or co-feed amino acids, you protect that. If you give people a reduced carbohydrate, high protein diet compared to the normal carb, normal protein, you get a reduction in liver fat in NAFLD with and without type 2 diabetes. There's also emerging data that suggests this is a signaling effect of amino acids. So 100% high protein diet is effective for fatty liver.
All right. Thank you, Dr. Guess. That was absolutely spectacular and a great way to start off our conference.